Hello and welcome to this presentation on osteoarthritis. Let's get into it. Osteoarthritis is the most common type of arthritis worldwide. It can cause moderate to severe disability, which makes it the 11th most debilitating disease worldwide. In the U.S., 80% of the population over 65 years old have radiographic evidence of OA. However, only 60% are symptomatic. On average, there's around 1 million hospitalizations of OA yearly, and it is the second most expensive disease in the United States, costing us a total of $15 billion so far. The definition and pathogenesis of osteoarthritis. The pathophysiology of OA is a multifactorial biopsychosocial process, and it's still being studied. Initially, OA was considered to be just due to wear and tear of the joints, especially the weight-bearing joints. However, multiple factors contribute to the pathogenesis of OA, like pro-inflammatory mediators and protease. OA starts to develop at the articular cartilage, which is also known as the shock absorbers, which then start to erode and progress down to the bone. The collagen matrix is then damaged, leading to the proliferation of chondrocytes, which then cause cluster formations. The cartilage outgrowth cluster formations then ossify and form osteocytes. The damage to the collagen matrix causes apoptosis to the chondrocytes, which then presents what is found on imaging, which is the subchondral bone thickening. In advanced OA, phosphate dihydrate crystals are present, which is believed to be the cause of the synovial inflammation and hypertrophy. Moving on to etiology, the etiology of OA is broken down into two subcategories, which are primary and secondary. Primary OA is the most common subset of the disease and is diagnosed in the absence of predisposing disease. In contrast, secondary OA occurs with pre-existing joint abnormalities such as trauma, congenital joint disorders, inflammatory or infectious arthritis, avascular necrosis, osteoporosis, Paget's disease, osteochondritis, hemochromatosis, Wilson disease, Marfan syndrome, or Ehlers-Danlos syndrome. Risk factors associated with OA is that OA is the most common articular disease in the adult older than 40. Women over 50 are more likely to have OA, and women represent 74% of the OA cases in the middle-aged and elderly. There are 90 genetic markers for risk factors for developing OA, which some of them were listed on the previous slide. Joint injury from occupation, sports activities, or trauma causing wear and tear to the joint or damage to the articular cartilage are additional risk factors. An example of this is people who have a history of cruciate ligament or meniscal injuries are at higher risks for developing due to the existing damage to the cartilage. Obesity combined with sedentary lifestyle, which is a huge epidemic in our country, creates a biomechanical issue like muscle weakness and abnormal gait. All this can contribute to the development of OA, especially in weight-bearing joints like the hips and knees. Obesity causes mechanical stress and can damage those weight-bearing joints. Finally, low fiber, high fat, and low levels of vitamin C and D have an increased risk of developing OA. Moving on to subjective data and symptoms. Typically, pain is the first symptom that presents. The first joints that are usually involved are in the hands, and these joints, the pain associated with them also interferes with the patient's activities of daily living. For most people, OA develops in 3 stages. The first stage is sharp pain in the joints that is predictable and brought on by mechanical insult, i.e. overuse. Stage 2 is pain that is constant and affects their activities of daily living, which is episodic in nature and also contributes to having increased stiffness in the joints. Stage 3 is when you're having constant aching and dull episodic pain that is unpredictable and intense, which causes limited mobility. Classic symptoms of OA are pain that worsens with activity and betters with rest. A key classic to remember with OA is that joint stiffness occurs in the morning, but it only lasts 30 minutes, and it also causes decreased range of motion. OA can present in the proximal and distal interphalangeal joints, the first metacarpal joint, the first metatarsophalangeal joints, the hips, the knees, the lower cervical, and lumbar spine. OA can also be monoarticular or polyarticular, meaning that it can affect more than just one joint. Moving on to clinical findings. Typical clinical findings include bony enlargement, crepitus, infusion with limited range of motion, and point tenderness along joint lines. If there's one thing that you should remember from this lecture is that osteoarthritis is present with Herbergen's and Bouchard's nodules, which you see here on the images to the right. Often these clinical findings are confused with rheumatoid arthritis. However, Herbergen and Bouchard nodules are strictly associated with OA. Herbergen nodules are swelling to the posterior lateral DIP joints, and the Bouchard nodules are swelling to the posterior lateral PIP joints. Since we just covered the clinical findings associated with OA in the hands, I thought I would discuss the physical examination that you might see with someone with OA involving the knees. Physical examining of the knees begins with inspection of the knee. Have the patient stand or be supine. The provider should examine the quadriceps and the calves for atrophy. If you see on the photo to the right, you will see the examining knee alignment. The knees should be aligned. However, if they're not, this will show joint space tightening in the medial and lateral compartments of the knee. The knee should then be palpated for an effusion, tenderness along the joint line, and for temperature. There should be an absence of heat present. The clinician should then check range of motion of the knee to determine if pain is elicited, if there is crepitus or clicking or locking of the knee. Additionally, stiffness rather than laxity is the hallmark sign of OA, meaning that a anterior and posterior drawer tests are unnecessary for the examination portion of the knee. Let's move on to differential diagnosis. The most common differential diagnosis is rheumatoid arthritis, which, like OA, both affects the joints. The diagnosis of RA is made when you're examining specific joints. You'll see to the right that there is a chart differentiating between RA and OA. But with RA, typically the metacarpophalangeal and proximal interphalangeal joints and the wrists are affected. OA affects the distal interphalangeal joints and is present with the Herbergen's and Bouchard's nodes, which we discussed earlier. In OA, the joints are swollen and hard. In contrast to rheumatoid arthritis, the joints are soft, warm, and tender, noting that warmth is a key differential. Pain with OA is spread through the range of motion in a joint, while RA occurs towards the end of the movement. Both RA and OA present with stiffness. Stiff joints in RA are worsening after rest, and the joints are worse in the morning, while stiffening with OA worsens with movement and in the evening. Rheumatoid factors is the critical diagnostic test to differentiate between OA and RA. In OA patients, their rheumatoid factor will be negative. Psoriatic arthritis is also a differential. This causes pain along the distal interphalangeals, but only affects one finger and not multiple joints like OA. Crystalline arthritis, which is also known as pseudogout, creates a chronic polyarticular swelling involving the fingers, wrists, knees, and other large joints. Those with crystalline arthritis will present with a tophi versus a nodule, which is seen on OA. Additionally, imaging will show articular chondrocalcinosis with crystalline arthritis. Moving on to hemochromatosis, this occurs when there is an iron overload. It is present in the MCP joints and the wrist, and it's predominantly in men. Those with hemochromatosis will have squared off bones at the end and osteophytes in the MCP joint, and is most common in the second and third MCP joint. Infectious arthritis is another differential. Infectious arthritis is present with inflammatory signs like OA, such as painful synovial fluid, but in infectious arthritis, there is warmth and erythema present. Those with infectious arthritis may also have a systemic component to their illness, such as fever and leukocytosis. Hip pain is a common complaint with OA, and sometimes that could be difficult to distinguish between a labral tear, avascular necrosis of the femoral head, or greater trochanter bursitis. To differentiate, the provider needs to take a detailed history and conduct radiographic imaging. Speaking of radiographic imaging, let's talk about laboratory and diagnostic testings. OA can be confidently diagnosed on physical exam and history. If the patient has the following presentations, then the OA can be concluded. Like, the patient is less than 45 years old, has morning stiffness that lasts less than 30 minutes, has bone joint enlargement, limited range of motion, and persistent use joint pain. If they do not meet any of these criteria, further workup can be conducted. Radiographic imaging can be used, but is not always routine. X-rays of the affected joints can show marginal osteocytes, joint space narrowing, like on the image to the right, subchondral sclerosis, or a cyst. An MRI may be performed if needed to detect OA in early stages, but it's not routinely done. A provider can also perform a synovial fluid tap and collect a sample. Yet again, this is not routinely done. Blood work such as CBC, ESR, a CRP can be used to exclude other diagnoses. And a final test that can be done is rheumatoid factor, and this can help differentiate between OA and RA. The management of OA starts with simple non-pharmacological interventions. The goal of non-pharmacological interventions is to decrease pain and decrease function loss. Non-pharmacological interventions should be activities that will reduce exacerbation of pain, like performing aerobic exercises and strengthening exercises with resistant training. This has been proven to improve function and decrease pain. A 10% weight loss by exercise and diet has also shown to reduce pain by 50%. Occupational therapy for unloading joints via brace or splinting, canes or crutches are also beneficial. Splinting of the thumb is also highly recommended for the MCP joint. Finally, surgical intervention can be used. However, that is reserved for when conservative therapies have failed. The total joint replacement of the knee and the hip is the gold standard for treatment for severe OA. Now let's talk about the pharmacological interventions that can be done for the management of OA. Pharmacological management is for those who have not responded adequately to non-pharmacological measurements. Pharmacological management of OA is a stepwise process. Ideally, we start with the least invasive, and further therapies can be added with frequent reassessments. Medications should only be used when the patient is symptomatic, since medications do not provide disease modification. Those with one or few joints affected by OA have shown similar results with topical NSAIDs compared to oral, with less systemic risks that are usually seen with oral NSAIDs. However, those who have inadequate symptom relief with topical or have multiple joints or large joints like the knees and the hips typically see better results with oral NSAIDs. Since OA is a disorder of the elderly, clinicians must consider that the patients have comorbidities like gastrointestinal, cardiovascular, or kidney disease. In a study by Richard ETA 2023, he examined the best medications for OA and determined that oral NSAIDs, including COX-2 inhibitors, are the best first-line treatment for OA because they improve pain and joint function. However, there is high risk associated with specific comorbidities. Duloxetine is routinely used for OA for people who have comorbidities in which NSAIDs are contraindicated, or for those who do not respond well to over-the-counter NSAIDs. Duloxetine is an antidepressant that has shown to work with musculoskeletal pain, fibromyalgia, and neuropathic pain. Providers must check the patient's home medications before prescribing duloxetine just to ensure that there's no drug interactions to decrease the risk of serotonin syndrome. Topical capsaicin can also be used on one or a few joints, although it is limited just to the joint. The benefit of capsaicin is that it has few side effects. The continued use of capsaicin can cause desensitization of the nociceptive fibers, which inhibits pain stimuli, which is a great benefit. Opiates are rarely prescribed. However, they can be used as a short term for pain management for those who are awaiting surgical joint replacement. They should typically be avoided because they have poor efficacy and they have an increased risk of harm. If you do decide to prescribe an opiate, you must start with the lowest dose possible that will be successful in controlling the patient's pain. For those with OA and have not had success with topical or oral NSAIDs or other interventions, they might want to consider intra-articular hyaluronic acid injections. However, this is not recommended for many because there's little evidence to show if it's beneficial over a placebo. However, some providers still perform it because it has a small clinical irrelevant benefit and its intervention can be given to a patient in a timely manner. Something also to consider if you are going to do an intra-articular injection is that you have to wait 3 months to have a joint replacement because of risk of infection. Moving on, there has been a lot of controversy over the intra-articular steroid injections due to their short duration of effect and their increased risk of accelerating OA progression. However, some providers still perform them as an adjunct therapy. Whenever performing this, you must consider risk versus benefit. This would not be something you would do in a young patient, considering it does increase the acceleration of the OA. However, it does provide some relief to people. Finally, we're going to move on to the total knee replacement option as a non-pharmacological intervention for OA. The total knee replacement is for those who have failed conservative measures that were previously listed and have joint space narrowing in 2 or 3 of the knee compartments. The knee is prone to OA just because of the fact that it is a weight-bearing joint. When performing a total knee arthroplasty or total knee replacement, the surgeon reconstructs the distal portion of the femur and replaces that with a prosthetic, and they replace the proximal portion of the tibia. They then add a cushion in between both of the replacements. This has a successful rate of 80%, meaning that 80% of people who have total knee replacements do have a reduction in their pain after their surgery. Once their surgery is complete, they do need to follow up with their interprofessional team, such as following up with physical therapy and, if needed, occupational therapy. I want to thank you for spending some time with me and learning about OA. I hope that this slideshow was beneficial for you.